Hello guys, good evening. Welcome to the 5 p.m. Fundus walk. So Sunday 5 p.m. we do the Fundus walk. So I hope you already know what is the topic or what is the fundus that we're going to discuss today. Anyone has any idea? If you've seen my, or maybe I think it's there in the post itself. And if you've taken a look at today's Instagram question, you already know. Hi, good evening, Vinodji. Good evening. All set? Shall we do the fundus walk step by step? All right. So by now, if you've been watching my fundus walk shows, you know which side fundus we are looking at. By now, you must be knowing. So at least now, tell me which side fundus is this? Which side fundus is this, guys? Come on, put it in the chat box. Which side is the fundus? Take a look at the optic disc. Yes, take a look at the optic disc, which is nasal in location. So which eye are you looking at as you see it? I don't want the diagnosis. Just say which side fundus are you looking at? Is it the left fundus or the right fundus? Is it the left fundus or the right fundus, bache? See, the optic disc is always nasal in location, and what I've marked that dotted circle, that is your macula. Macula is temporal. So if this is nasal, so that means your nose is here. So you're looking at the right fundus. Okay, you're looking at the right fundus. And what I've marked as V. Okay, so can you see that little darker red and a little thicker one? So that is your vein, and just next to that is your artery. Yes, so you can see the vein which is little darker and thicker. Very good, Vinod. So this is your vein, this is your artery. The normal A is to V ratio is 2:3, but this is not 2:3. This is even more thinner. The artery is even more thinner, or an attenuated artery that I can see here, because this is an atherosclerosed patient. Yeah, so the normal AV ratio is 2:3, but this is not normal. This is kind of 3:4. I would put it as the artery is a little thinner, or what we call arteriolar attenuation. And what I want you to notice here is look at the color of the fundus between. What happened? Okay. So compare the color of the fundus between this portion and in this area. So can you see the normal color of the fundus? Because the retina is transparent and you can see the choroidal orangish red color. Whereas here, in the major portion of this macula, you can see it is pale because there is retinal edema. Although you might ask me, ma'am, where is the milky white? It's pale. Okay, there's a retinal edema. But bang in the center at the foveola, yeah, this whole thing is macula. This area would be fovea, and the center of fovea is foveola. So at the foveola, do you see a nice bright cherry red spot? Yes. Do you see a nice bright cherry red spot? Yes. Now, why is that area red? That area alone is red. So I will just tell you first the pathophysiology behind cherry red spot. Yeah. See, it all boils down to anatomy. That is why I always keep telling you, learn anatomy very, very well. You don't have to mug up anything. See, at the foveola, the ganglion cells are absent. Yes, the ganglion cells are absent. Then you might ask, ma'am, how do we see? See, first of all, you need the photoreceptors. Photoreceptors in that area are there. Okay, only the ganglion cells are not there. So when you get retinal edema, for whatever reason, okay, so when you get a retinal edema, the retina becomes opaque because the ganglion cells, there is intracellular edema. Yeah, because the ganglion cells are going into the apoptotic pathway, and you all know an apoptotic pathway. Okay, basic apoptosis. Okay, so there is release of intracellular calcium and there's intracellular edema. So the ganglion cell is edematous. So now when I'm seeing this edema blocks my underlying choroid. I can't see the choroidal orangish red color. That is exactly the reason why this area is all pale. Can you see the pale area? Oh, so what we call milky white edema. So this area is pale, the macula is pale because it is edema compared to the rest. But at the fovea, there are no ganglion cells, even anatomically, normally none of us, the ganglion cells are not there. So there is nothing to block the choroidal fluorescence. So the choroidal color, choroid is highly vascular, no, highly vascular. So you can see the blood red, cherry red spot. Yeah. Now, there's a lot of differential diagnosis for cherry red spot. Now, why would I call this as CRAO, central retinal artery occlusion? Good evening, BU. Miss you in the morning, beta. Paya. Right. So, here I call it CRAO, the whole clinical picture, because cherry red spot is seen in a lot of conditions. Why do I say it is CRAO? Because the most common cause of CRAO is your hypertension, atherosclerosis. Yeah. So can you see the artery is so thinned out? It is so thinned out. Yes. No problem, BU. You can always watch. No problem. Okay. So the artery is very thinned out. There is generalized arteriolar attenuation. Okay. And there are also some AV changes also. So that is seen. So this is central retinal artery occlusion. So can you all tell me, other than central retinal artery occlusion, what are the other differential diagnoses of cherry red spot? Oh, okay. No problem, BU. No problem. But you will really love the clinical scenarios discussion. Right. So this is central retinal artery occlusion, where you should see, like I keep telling you, you look for the cherry red spot in the midst of a white frosting. You all eaten white forest cake, no? Black forest cake I know is your favorite, but white forest cake also is good there, no? So you see the white forest frosting, and in the white frosting you see a cherry. That is your cherry red spot. Okay. Very good. Niemann-Pick, Gotch. Okay. Tay-Sachs. Yes, very good. Gotchers, there's only one thing that you should remember. Gotchers, not all types of Gotchers have cherry red spot, only type 2. Gotchers only type 2. You write G, no? You write like this. Gotchers only type 2 has cherry red spot. Okay, very good. Berlin's edema, very good. Very good. Berlin's edema seen in blunt trauma. So you can get cherry red spot in blunt trauma as well. So you see the whole clinical picture and then come to the diagnosis. Okay. So just the fundus image alone for you, it might be difficult. Right, it might be difficult for you, but I also explained in this case, this particular fundus, this is a right-sided fundus. It is a central retinal artery occlusion because we do see atherosclerotic changes as well. Yeah, clear? So shall we quickly take a look at what we saw last week, last Sunday? So last Sunday it was branch retinal vein occlusion, because one quadrant you get this splash tomato appearance. If you see the whole retina full of splash tomato and the egg, then it is central retinal vein occlusion. This is CRVO. Okay, so now you cannot confuse between the three. So you know for sure what is CRVO, what is BRVO, what is CRAO or cherry red spot. Yes, very good. Very good. So CRVO, perfect. Perfect. You'll never make a mistake. FNGs. Exam is coming, fundus, yours is the first exam. Then the same tomato splash in one quadrant, that is your branch retinal vein occlusion. So all the three, whether it is venous occlusion or arterial occlusion, the most common cause is hypertension. Okay, so some students, some of you ask, ma'am, then why you are saying atherosclerosis? Atherosclerosis only causes hypertension, no, most of the times, at least elderly, that is a underlying pathophysiology. So that is why some of the options, rather than giving you hypertension, they give you atherosclerosis. Okay, is that clear? Okay, now let's, one last time, let's take a look at our central retinal artery occlusion. Yes, so that is your right-sided fundus, because my optic disc is here. This is my macula and my macula is pale. Okay, I would want to call it milky white retinal edema. And there is a cherry red spot, and I want you to see the arteries and the veins. see, the vein is little darker and a little thicker. The artery is thinner and a little lighter. Normally, AV ratio is 2:3, but this I would put it not as 2:3, probably as 3:4, because my artery is more thinned out because of the atherosclerotic changes. So I'm looking at the whole picture with the generalized attenuation of the arterioles plus the cherry red spot, and that is why I'm calling it CRAO. And CRAO is an ophthalmic emergency. Is that clear? So CRAO, there will be pupil abnormality. There will be RAPD plus RAPD. Yes, relative afferent pupillary defect. But in case of your Niemann-Pick, Tay-Sachs, then your metachromatic leukodystrophy and all that, there the pupil will be normal. Yes, there will not be RAPD. There will be cherry red spot. Please remember that. Your storage disorders that cause cherry red spot, pupil will be normal. Is that clear? Is that clear? So central retinal artery occlusion is an ophthalmic emergency. 90 minutes, 1.5 hours is a retinal anoxic time. Yeah, theoretically. But because we do have collaterals normally, so around 6 hours. So 240 minutes, 6 hours is a golden period for treating CRAO. First thing, massage the eye, ocular massage. Number 1. Number 2, reduce the intraocular pressure drastically. Best do paracentesis. Just put a needle into the, even a 26G needle or a 30G needle, just put it into the anterior chamber, remove a little bit of the aqueous, the pressure will fall down. Paracentesis. Or give IV mannitol or oral acetazolamide. Bring down the pressure very, very rapidly. Yes. Then address the underlying cause. Treat the hypertension, and you can give your fibrinolytics, RTPA, to dissolve the clot. All that can be done, but emergency management first. Yes, so treat the hypertension and look for the carotid plaque, which is sending out the emboli. That's not my management. That is what the internist or the cardiologist is going to manage. But at my level, what I will do is ocular massage, intraocular pressure I will try to reduce, and there are some extraordinary procedures that can be done. And this intravenous vasodilator and all, I will not give. Ophthalmologists will not do such things. We will refer, but before referring, do all this emergency management, and also make the patient inhale carbogen. That is very, very important, because carbogen has a vasodilatory property. Okay, in CRAO, see, ocular massage help at the end of your own hands, or either the patient himself can massage, or you nicely massage the patient's eyes, and make the patient inhale carbogen. Where will we go for carbogen? Just give the patient one plastic bag or a paper bag, tell him breathe in and breathe out of the same bag. So when you breathe in and breathe out of the same bag in the patient, obviously the exhaled air has more, Hava has more carbon dioxide. So the carbon dioxide concentration will increase as you repeatedly breathe in and out of the same bag. And that increased carbon dioxide will dilate the vessel wherever the block is. Yes, embolus is blocked somewhere, no? Most commonly at the lamina cribrosa. Most commonly at where the central retinal artery pierces the optic nerve. Where it pierces, that is the area where this clot or this embolus has come and blocked the central retinal artery. So you need to dilate the artery. So you can ask the patient to inhale carbogen. And what is the concentration of carbogen? Usually by the time the patient inhales and exhales into the same bag, it rises to 5% carbon dioxide. You don't go running for carbogen cylinders, okay? The oxygen cylinder only is not available, LPG cylinder only not available. So carbon dioxide 5%, that is very, very important. So that is vasodilatory. So these three things, that is ocular massage, decreasing the IOP primarily by doing a paracentesis, or giving IV mannitol or oral acetazolamide, because these are rapid onset drugs. So these are in my hands. And number 3, this carbogen inhalation. Now the rest, like in giving intravenous vasodilators or your RTPA, all that is the jurisdiction of internist or medicine person or your cardiologist. So I don't want to waste time by sending the patient there first. I do all this and then I call up my friend. I say, please take care. Emergency, please manage. Yes, so that is the management of CRAO. And patient has to cut down salt. Guys, all of you, see, like small things, like even I teach you, hypertension, salt has to be cut. Salt intake. Please remember, because you have parents, you have grandparents, elderly people around you, and we are also aging. And even when you're young, please do not take too much of salt, okay? Because it's very cumulative. It compounds, just like money invested compounds. These bad habits also compound. The bad effects compounds. So hypertension, first thing is, apart from your central retinal artery occlusion itself, I'm talking about hypertension, salt intake has to be reduced. Okay, so please put that into your head as practitioners, because you all are going to practice and you have to advise this to your patient, because patients just don't know. Okay, patients just don't know. They'll keep popping that medicines day in, day out for years, and the BP is not coming down. And then you see them, they're sitting and eating the papad. 10 papads they will eat, 2 papads they will eat, 2 appalam they will eat. No, and no pickles. Okay, so as doctors, it is not just important that you crack MCQs. You should know every person, hypertensive patient, make sure, take some time to counsel, because the comorbidities and the morbidities, okay, not just the comorbidities, the morbidity because of hypertension is very high. Okay, so that is important. And CRAO also, please remember, once the patient has a CRAO, also evaluate the patient for subsequent risk of stroke. So they need a cardiac evaluation. They also need a neurologist evaluation, or at least for follow-up. So they are very likely to go in for stroke, because the embolus that is coming into your ophthalmic artery from the common carotid your ophthalmic artery, and blocking your central retinal artery can also go way up, right? So they are at risk of cerebrovascular accidents. So they need to be followed up with neurologists as well. Please keep this in mind. Yes. Uppumanga, amma, ella sapruvanga. They will eat uppumanga, they will eat koyapalam with uppu, everything they will eat. Pineapple also they will eat with salt, everything they will eat. Okay, so guys, so I will see you at 6 p.m. with the images decoded session. All right. You also know, Oppo mango. All right, Oppo mango is salt mango. Okay, I'll see you at 6, guys. Ciao. With all the images that we did for the last week, we will do it at 6 p.m. Chalo, bye-bye.